Bismillahirrahmanirrahim. Today we will discuss complex renal cystic lesions, their classifications, their investigations, mode of management, and case-based review study. Case 1, patient is 70-year-old female, presented with hemoptysis, recurrent epistaxis, renal impairment. Serum creatinine level 10 mg on presentation, diagnosed with renal biopsy proven vasculitis. Required ICU care, hemodialysis and rituximab. Creatinine stabilized between the 3 and 4.5 of maintenance dialysis. Ultrasound abdomen pelvis suggestive of incidental asymptomatic bilateral renal cyst with a 4.5 centimeter complex cystic lesion in the upper renal pole. Subsequent MRI abdomen and MRI kidney with a contrast confirmed bilateral simple lower pole cyst with a 4.5 centimeter complex left upper pole cystic lesion with the enhancing soft tissue component. Similar 2 centimeter lesion noted in the mid region of the right kidney. So these are the findings of the MRI. Ultrasound pictures showing the cystic lesions. So this is the MRI kidney with the contrast. Here we can see the cystic lesions with the enhancement of the components, solid component. This is the cystic lesions. Case 2, 68-year-old male, background of diabetes mellitus, hypertension and benign prostatic enlargement, known CKD, serum creatinine 1.6 with eGFR 41. Presented with the urinary tract infection, pyelonephritis and acute on chronic renal impairment on surveillance since December 2020 for 5 centimeter unchanged complex upper pole renal cystic lesion. So basically this patient is on active surveillance from December 2020, showing the 5 centimeter lesion, unchanged lesion. So this is ultrasound. Cystic lesions we can mark here. This is the cystic lesion. So right and left kidney. Here we can see the cystic lesions MRI showing the complex cyst. Risk of surgery, worsening renal impairment requiring renal replacement therapy, risk of surveillance, potentially malignant lesion and risk of the progression and metastasis. So here we will discuss it on next slide. So this is the description, short description of the renal cyst, mostly simple by definition, asymptomatic and incidental, rarely symptomatic. Prevalence symptoms are just like pain on the flank area. Prevalence increase with the age, 1/5 of the adult by age 40 and 1/3 by age 60 will have a renal cyst. Hallmark of the simple cyst, do not communicate with the nephron or the pelvis, confined to the renal cortex, filled with a clear fluid, radiologically spherical, smooth and anechoic. Parapelvic cyst, basically Dr. Fawad is saying, can compress the pelvic ureteric junction, so it is more symptomatic than simple renal cyst. Differential diagnosis, cystic renal carcinomas 5%, adult autosomal dominant polycystic kidney disease, and that may be diffuse multiple bilateral cysts associated with a hepatic cyst, complex renal cyst. Hallmark of the complex renal cyst is a short description of the complex renal cyst. Irregular margins, septations, classifications, solid element, enhancements. So basically these two or three can differentiate with a simple cyst, irregular margin, septations, calcifications, solid elements enhancement more than 15 Hounsfield units, and hyperdensis, previous infection or bleed in the simple cyst do not enhance, usually less than 3 centimeter do not require follow-up. So this is Bosniak classification of the cystic lesions. So it is divided into 5 stages. Stage 1, here we can see stage 1, simple renal cyst with a regular margin with a clear fluid, no septations and no calcifications. This is stage 2, Bosniak classification, showing the septations with a clear fluid and regular margins, and confined to renal cortex, no communication with the pelvis or and stage 2F. F basically F mean follow up. Patient we keep patient on follow up, so that's why this stage is named as a 2F. So 2F category introduced in 1993. This is showing the calcifications along with the septations. So this calcification we advise patient to follow up. Stage 3, 50%, stage 2F 5% patient, 5% can be malignant cases chances, and stage 3 it's showing septations, multiple septations with the calcifications, and enhancement is which can differentiate the stage 3 from others. 50% patient are malignant, and stage 4 actually it is written wrong, 100%, actually it is figured 75 to 80%. 75 to 80% patient are malignant, showing the showing the septations, calcifications and enhancement and solid component in stage 4. So gold standard investigation is CT urogram, and we can do MRI if patient came with renal impairment. So creatinine is raised. In both patient creatinine is raised, came with a renal impairment. So we have done MRI with contrast. So here is a description of the Bosniak classification which I told you earlier. Stage 1, stage 2, stage 2F, and stage 3 and stage 4.
So what Faran previously?
So small renal masses account for 50% of the newly diagnosed renal cell carcinoma. 80% are malignant, low grade, early stage tumor. Basically, small renal masses we can classify on the basis of size. T1A lesions less than 4 centimeter.
That is the definition, small renal mass.
Yes.
Less than 4 centimeter.
In this cases, management option is active surveillance, watchful waiting, energy ablative treatments like radiofrequency ablation and cryotherapy. So cryotherapy is actually mechanism in which we we use low temperature minus 40, minus 30 degree centigrade, and radiofrequency ablation. Excisional surgery, in this we use a partial nephrectomy, or partial nephrectomy is called nephron sparing surgery, and radical nephrectomy. So partial nephrectomy is actually indicated in polar lesions, upper pole or lower pole lesions. So we can
even on the convex margin, so
yes.
away from the highlight.
Indication of the renal mass biopsy. Uncertain nature of lesion prior to systemic therapy, ablative therapy, and tumor surveillance. So tumor surveillance, actually we want to diagnose the nature of lesion, either is it benign or malignant. So if we are going to put the patient on active surveillance, we should know about the lesions, nature of lesions. Complex cystic lesion, identification of the complex cystic lesion renal masses has increased by 8 to 15% of the last decade. 50% of the Bosniak classification 3 and 25% of the Bosniak classification 4 lesions are benign. Management option, active surveillance, watchful waiting, excisional surgery, energy ablative treatment with the selected cases, Indication of the renal mass biopsy not usually recommended can be considered in selective cases. Actual idea is small renal masses about this size. If size is less than 4 cm, then we will put the patient on active surveillance or watchful waiting. And if size is 4 to 7, so it is upstage stage. Actually, less than 4 cm is T1A stage. So if 4 to 7 size increased renal mass, so we will go for management option, either partial nephrectomy or radical nephrectomy. Cystic renal cell carcinomas account for 5% of the renal cell carcinoma, usually low grade, low stage tumor with a low metastatic potential and excellent prognosis. Although surgical excision is suggested treatment of the choice for these lesions, there is an emerging body of the evidence suggesting that they can be managed safely by the active surveillance. To reflect this indolent behavior, the International Society of the Urological Pathology has recently modified its terminology and now recommend calling these lesions multilocular cystic renal neoplasm with a low malignant potential. Extrapolating from data on the short renal masses, it has been suggested that Bosniak classification 3 and perhaps even Bosniak classification 4 cyst with a solid component measure less than 3 cm could be managed with the initial surveillance. So here is again in this description is size. So if the lesion is less than 3 cm size, so we will manage it on the initial surveillance and active surveillance. And if the size increase, solid component increased, and chances of metastasis is increased, so we will go for management. Uncertainties in the radiological evaluation of the small cystic renal lesions, risk of the inter-observer variability in the accurate radiographic measurement to establish the subtle changes in the mass dimension. Size of the complex renal cyst has no correlation with the incidence of the renal cell carcinoma or tumor aggressiveness. During the follow-up of the cysts, changes in the internal architecture such as septa and wall thickening, actually again I am describing that Bosniak classification, thickening, nodularity are taken into account to demonstrate the progression. So if the septation is being increased or solid component is being increased, enhancement is being increased, then we can change our decision. When the active surveillance is employed, the same imaging modality should be used throughout the active surveillance in order to avoid the variability in the measurement between different techniques, at least during the first 2 to 3 years. So here he is saying that in the active surveillance, if we are doing CT with IV contrast, so we will do the same investigation throughout the time, at least initial 2 to 3 years, to avoid the variability. It is also important to measure the lesion on the same plane in the same direction and in the same slice. Recommend that the nephrogenic phase to reduce the variability. Close follow-up every 3 to 6 months for initial 2 to 3 years and then yearly. So this is a schedule of the active surveillance.
The yield won't be that good. It all depends. That's a very good question, and there's quite a bit of studies on that. You can try, but although there is it all depends who's doing the biopsy, what's the degree of nodularity or solid lesion. So, and the yield is usually good, but it all depends who's doing it and how experienced they are, because they are the interventional urologists, they'll just be doing these biopsies and their yields will be quite good. So if we ask someone to do it on an occasional basis, but we're right, a biopsy would help, because a lot of them will in retrospect can turn out to be hyperdense cysts as well, although there's no classical enhancement in them, but still that happens. So you can. What are the risks involved with the biopsy? With the biopsy, with the cystic tumor, as I said before, because of the cyst it can rupture. So although there's no evidence that there is malignant cytology, they're not malignant cytology is not positive with them, so there's a risk of rupture and theoretical risk of sealing and all that, but that's almost unheard. So there's no harm in biopsy, but again, because this is so much variability in these cystic lesions, so you have to take patients case by case and cyst by cyst. So for example, if someone has a significant chunk of a solid enhancing lesion or nodularity in there, then that is easily biopsiable. And then it depends where it is. If it's on the poles or the convex surface, then it's more accessible compared to if it's on a hilum. It's not different compared to a standard biopsy, to be honest. Yeah. So again, as we said before, what's the optimal management option? So it's a risk versus benefit ratio, like everything else in life and especially in medicine. So we all know that end-stage renal disease is a significant risk factor for mortality, morbidity, and specialized care. And we know that from this excellent study almost 20 years back. They looked at 1.2 million patients, general population with some degree of renal insufficiency, not on renal replacement therapy or transplant. And we can see very clearly there's a graded association of worsening renal function with increasing risk of death, cardiovascular event, and need for specialist care. So in other words, we need to protect and preserve renal function. So 15 years back, radical nephrectomy was the treatment of choice. In fact, the gold standard for any kind of renal lesions, even these small 4 centimeter renal lesions, but that's not the case anymore. And the reason is there's quite good going evidence that's come through. So this is a very important landmark study, looked at 700 patients, followed them up for 10 years between radical nephrectomy and partial nephrectomy. So these are all patients who underwent these for less than a 4 centimeter tumor with a normal kidney function and 2 healthy kidneys. And the template was divided into this left one cutoff was 60 ml per minute of EGFR and the right is 45 ml per minute. And you can see very clearly, for example, if you take the 3-year cutoff, you can see that almost 80% of patients who underwent partial nephrectomy after 3 years had a EGFR of more than 60 ml per minute, but only 1/3, 35% of patients with radical nephrectomy had a EGFR of greater than 60 ml per minute. And this is in patients who had supposedly had normal kidney function and 2 normal kidneys. If we look at the 45 ml per minute cutoff, let's take the 3-year timeline. So you can see almost 95% of patients with partial nephrectomy had a EGFR of more than 45. And 2/3, 65% of radical nephrectomy patients. So it's important. So radical nephrectomy is not the gold standard anymore. So in fact, what this showed us was that radical nephrectomy is an independent and major risk factor for worsening renal function. So that's out of the window now for small renal lesions. So if you don't operate, then what's the risk of progression and metastasis? In a simple answer is not much. It's quite minimal, and there's quite good going evidence for that. That's come over the last 15 years, and that's by looking and observing the natural history of enhancing renal masses. And if we look at small renal masses, for less than 4 centimeter T1A lesions, so growth rate is minimal, 1 to 3 millimeter per year, and risk of metastasis 1 to 3%, and that's after 4 or 5 years. Even they've compared it to large renal masses for patients for one reason or the other. They're unfit, not willing, multiple other issues, comorbidities, poor performance status, and they have been kept under surveillance as well. And even then you can see the growth rate and risk of metastasis is not that significant. So another study, very important one, a systemic review of 18 case series, almost 900 patients, 1,000 tumors, and you can see only 18 progressed to metastasis. This is small renal masses, less than 4 centimeter, and the mean was 40 months. And you can see the radiologists, and probably they can conquer a lot of these small renal masses. There are quite a few variables and formulas out there to count linear progression, volumetric expansion, all that as well. So I can tell you, before I left 2 years back, we had a lot of these patients on our books. At my last count, I remember almost 75 elderly patients with small renal masses. And what we would do is we would discuss them, run them through the MDT, all that, and they will be handed over to the urology kidney nurse specialist, and she will arrange for follow-up, MRI, CT, whatever. And then very rarely we would see someone coming back to the MDT, and that would even be after years. So these are that indolent lesions. So that's the other thing. So the guidelines, these are the American guidelines, AUA and American Society of Clinical Oncology, and the European guidelines, something similar as well. And what they're trying to tell us is that it's, at the end of the day, it's a risk versus benefit analysis. So you can see a relative indication of significant risk of end-stage renal disease. One of our patients already has end-stage renal disease. Thankfully, she's not on dialysis, but that can make things worse. So in other words, the take-home message in these patients, especially with degree of renal insufficiency, is that we have to preserve and protect the renal function, because preserving, protecting the renal function will probably be the most important parameter in their survival or to reduce the morbidity as well. So the take-home message is it has to be a pragmatic, practical approach. Depends. It has to be quite variable. Will depend on patient factors and tumor factors. What's the patient performance status? What's the tumor characteristics? What's the comorbidities and all that? And they have to be, because they are so variable and equivocal. So they are best managed in ambulatory setting with preferably a renal oncologist, urologist, and neuropathologist. But we can be assured that these renal lesions, they are slowly progressive, rarely metastatic, right? So we can do more harm than good if we just go in and operate everyone. So this is a classical scenario and situation where the old surgical adage holds good. So surveillance protocol for our patients, what I would recommend for case 1 is 3 monthly contrast MRI kidneys. She just was diagnosed in February, so it's still early days. The second one, we are quite reassured because he was diagnosed in December 2020, so it's coming up to 3 years. And more or less, his 5 centimeter complex cystic renal lesion hasn't changed at all. So 6 monthly MRI kidney should suffice in him, and preferably to be reported by the same radiologist in the same slice. So as I said before, this is a classical scenario where this old surgical adage, good surgeons know how to operate, better know when to operate, and best know when not to operate. I'm not implying by any stretch of the imagination that we urologists belong to the last category, but you learn this from experience and evidence. And to finish this, I would like to quote Robert Hutchison. We all know him from the Hutchison clinical methods in medicine. So this is a physician's prayer, and if you look at here, from treating patients as cases and from making the cure of the disease more grievous than the endurance of the same, good Lord deliver us. Yep. Thank you for your attention.